Good morning, everyone. My topic for presentation is to assess the short-term and long-term variations in intraocular pressure after intravitreal injection of anti-VEGF. To introduce, anti-VEGF have revolutionized the treatment of various retinal diseases, including neovascular ARMD, retinal vein occlusion, diabetic macular edema, etc. The VEGF is a signal protein produced by the Muller cells that stimulates vasculogenesis and angiogenesis. The anti-VEGF agent ranibizumab is derived from the murine antibody to VEGF. Intraocular pressure elevation is a significant concern both in short term as well as long term after the use of anti-VEGF. The objectives of my study were to study the short-term and long-term IOP elevation seen in patients receiving intravitreal ranibizumab injection and to study the correlation of the number of anti-VEGF injections to that of IOP elevation. Our study was a prospective hospital-based clinical study conducted in Regional Institute of Ophthalmology in Banaras Hindu University over a period of 1 year. All vitreoretinal cases with indication of intravitreal ranibizumab who provided written consent were taken into inclusion criteria, whereas patients with history of glaucoma on long-term steroids with corneal abnormalities and patients with a history of intraocular surgeries were excluded. 100 patients were screened and 65 patients were selected with the indication of intravitreal anti-VEGF. The data collected included patients' detailed history, including previous ocular history and systemic disorders. The baseline intraocular pressure was measured before the injection, half an hour after the injection, and at various follow-up visits at week 1, 3 months, and 6 months using applanation tonometry. The intraocular pressure at 6 months was compared to the baseline and to the number of injections received. In procedure, 0.5 mg of ranibizumab was taken in 0.05 ml and was injected using the pars plana route using insulin syringe of 30 gauge under full aseptic precautions. Post-op, the patients were given topical medications in the form of antibiotic eye drops. Oral carbonic anhydrous inhibitor was only given if the IOP persisted more than 30 mmHg at the end of half an hour. It was observed that around 55 patients were male, whereas 44 patients were females. Most of the patients had the age group lied between the age group of 51 to 60 years, and the major etiology was diabetic retinopathy with macular edema followed by ARMD, followed by vein occlusions. Majority of the patients experienced short-term pressure spikes soon after injection that normalized within 30 minutes without any further intervention. It was seen that the baseline IOP was 14 mmHg that increased to 15 mmHg at the end of 6 months. That was normal. And it was also seen that the mean IOP was more in patients who received more number of intravitreal injections. However, there were 6 such patients who had persistently elevated IOP at the end of 6 months. In these patients, the baseline IOP was 15 mmHg, whereas that at 6 months was 24 mmHg. To discuss, in short-term changes of IOP, it has been in various studies that the IOP reduces to less than 30 mmHg in 96% of the injections by 15 minutes and in 100% by 30 minutes. The eyes with a history of glaucoma took longer to normalize. The short-term variation in intraocular pressure is related to the increased intraocular volume following the injection, whereas in long-term studies, there has been shown that serial injections of anti-VEGF may lead to persistent IOP elevations that might require glaucoma therapy. In this study, after a mean of 20 injections, the mean IOP was 29 mmHg as compared with a baseline of 16 mmHg. The syringe used to inject the drugs might contain silicone oil droplets that can mechanically obstruct the trabecular meshwork. To conclude, the necessity of post-injection intraocular pressure monitoring is to identify patients who are at high risk for delayed normalization and those who developed sustained elevation of IOP post-injection. The recent guidelines recommend that there should be monitoring of intraocular pressure after injection and providing therapy only when elevated IOP warrants intervention. The limitations of my study was there was a small sample size, it was a single center study, and our study failed to conclude what were the contributing factors for persistent rise in intraocular pressure. These are my references. Thank you.
For the benefit of some of our younger colleagues here, kindly state did you take, I mean, how did you sanitize or sterilize the tonometer head? Because you were checking the pressure just before injection, half an hour after injection, and thereafter, though it's okay. So for prevention of infection.
So in our setup, we use alcohol and to sanitize the head of the prism base, and then followed by a clean cotton gauze, and then it is dried up, and then followed by tonometry.
Out of these 65 patients, how many were known glaucoma patients?
None of them; those were taken in the exclusion criteria.
But then in the conclusion, you said the glaucoma patients took longer.
Yes, in different studies it was shown.
Sorry?
So it was shown in a different study that we discussed there.
I think it's, this so many injections are being given. So it's an important to know what you have brought out for everybody is that intraocular pressure needs to be monitored.
Yes.
And I think what Paritosh said, that measuring the intraocular pressure is important to do it in a sterile manner. So each of us develops their own technique of doing it. I do it with a 30 gauge needle. With the same needle, I just touch over the cornea and see how much bending occurs, and that way it gives me a gauge of how much pressure is there. And then you ask the patient, are you able to see the fingers? So that works very well, but I think, yeah, that's important. You could also use other tonometers which use the nitinol filament, which is disposable at every